Okay, so the topic for this evening is ridge preservation after tooth extraction. And since I'm a prosthodontist, I want to stretch it as far as actually saying that this is setting the foundation not only for implant treatment, but for any prosthetic treatment in the future. So I think that should be the topic of this evening. And there are a number of questions that we're going to find the answer to. One of them, of course, is what happens when you extract a tooth. We're also going to look into the fact that what happens when you extract a tooth and when you put something into the socket, and the factor that actually it reduces the dimensional change of the alveolar ridge. So the concept of ridge preservation per se. We're also going to look at how you perform ridge preservation. And we're also going to talk a little bit about what materials you actually can use. So those are the things that we're going to answer during this webinar this evening. But we're going to start first with setting the foundation for this, because there are extensive research done on this topic in the past. So it's not something that is actually new. We have extensive research actually proving that this is a good concept treating your patients. So when you extract a tooth, there are a number of biological events that is triggered inside the body of a patient. And of course, there's atrophy. And we know for sure that there's a resorption of the alveolar bone, and there's also partially some loss of soft tissue. And this all happens during the first few weeks after extraction. And what you see here, there are a number of studies that have been focusing on these biological events. The extent of the bone remodeling process, well, it of course depends on some local and systemic factors. But we all know what happens inside every patient's mouth. And there is a horizontal and vertical reduction of the ridge, and mainly in the buccal coronal aspect. Now, ridge preservation procedures, of course, they are aiming to decrease these events that follow tooth loss. But what is also important to point out that it's actually minimizing the need for additional augmentation in the future, prior to when you deliver any type of implant or tooth-supported restoration. So what we're doing here is actually avoiding second stage surgery, which of course increases the pain, the cost, and morbidity of our patients. So this is what we're trying to avoid by simply doing something when we extract the tooth. And again, we have widely researched this topic over the years. And what it says here in this study is actually that it's indicated not only for a specialist, but for any general practitioner. So for the contemporary dental practice, you can all perform this on a daily basis. And there's a solid evidence supporting how effective it actually is. And all these systematic reviews all have the same proof for this concept. Now, on some statistical notes, if we look at Sweden, where I'm practicing as a prosthodontist, last year, 2020, Swedish dentists extracted in total 580,000 teeth. That's a lot of teeth. Now, if we look into my clinic, or one of my clinics, we extracted 890 teeth. So almost 1,000 teeth just in one of my clinics. But there's a huge problem here, because with the majority of teeth that are extracted and replaced, they most likely are done by general practitioners, but very few of them actually perform ridge preservation procedures. So of course, that is something that we have to remedy. Now, I'm going to show you some different cases here. And this could be sort of a scheme and a sort of walk through as to what type of cases you could actually choose when you go home and you practice tomorrow. So if we look at the single tooth space first, and we're talking about a fixed partial denture. So this is not an implant case, but this is a normal bridge case. Now, of course, the key rule here is that when you do the extraction, you do it automatic in every situation and clinical case. So that means, of course, when it's a molar, you section out the roots. You make sure that you don't traumatize the surrounding tissues. So we're not going to go into all the techniques there today, but this is, of course, important to stay out before we start doing the ridge preservation. Now, Of course, you have to ask yourself, what type of prosthetic treatment are you looking for? So what type of replacement? Well, it's the dental implant, where we know with immediate placement and early placement cases. This is perhaps not the case where we do ridge preservation, because when we do these treatments, we usually do simultaneous GBR. An early placement is only 6 to 8 weeks after extraction, so again, this is not the case for ridge preservation. But we also have to realize that most of the cases with dental implants, especially in the market here, are late placements. So, and the late placement here, obviously, it means a normal healing period of maybe 10 to 12 weeks. And this is actually most of the implant cases on different markets. And with a fixed bridge case, well, of course, then we're looking at the Pontic sites, like the X-ray you see here, where you extract the tooth. So these are the two situations that we're going to look at. So again, the late placement, we wait a few weeks before we actually place the implant. So again, we're trying to preserve the bone and the soft tissue as much as possible. And also, of course, the fixed bridge situation with the Pontic site. So here we see a young female patient. She has a trauma and acute pain. She's done initial trauma treatment, but she's very much afraid of the dentist. We have multiple fractures on neighboring teeth. And since this is a patient that is very scared, there's a lot of pain, we will not move on with any type of immediate placement of implants. So this is a case for ridge preservation. So we gently, of course, extract the tooth, make sure to use, for example, periotomes, remove the tooth, and of course try to save the buccal bone plate at the same time. But we're going to do ridge preservation. So we're going to fill the socket with a xenograft and a collagen carrier. We're going to seal off the site with a resorbable membrane and sutures, and we're going to wait for healing 10 to 12 weeks before we install the implant. So you see the lower X-ray CBCT slide, you see that we've really preserved what is there. Now, of course, when we place the implant, we can additionally put grafts if that's what we're aiming for, but we have kept the tissues there, and this is the important thing. So when we look at the final case here with this female patient, it's almost impossible to see where the implant is, but the implant is here on the left lateral incisor, and we've kept the tissues in place. So we avoided unnecessary secondary surgical treatment. Of course, it saves time and cost for the patient, and it's more efficient. So this is an important indication for ridge preservation. Then, of course, when we go back to this case here, well, this is a slightly older patient, a female patient. She has avoided dental treatment due to COVID-19 pandemic. She has a previous old PFM crown on the second premolar. There's fillings on the canine. So this is perhaps a patient where we're not aiming for an implant treatment, but we're just looking at a simple fixed partial denture. But at the same time, we want to keep the tissues at the Pontic site. So we still want to have function and aesthetics over time. So again, we divide this tooth, we gently extract the tooth. Again, atraumatic extraction is the first key. Any type of granulation tissue, thorough debridement, use of course saline solution, and you create a fresh and healthy site and a clean site before you start the preservation procedure. So what material could we use here in this case? Well, of course, there are different materials on the market. In this single edentulous space, well, the recommendation that we've seen in research over time is to use an osteoconductive bone graft material with a slow resorption rate and coverage with a resorbable membrane. So this is a simple, straightforward technique that you as a general practitioner can perform tomorrow in your daily practice. What also said in research is that soft tissue grafts or a full primary closure, it's not beneficial. And what does it mean? It means that you don't have to have an extra secondary surgical site to have soft tissue grafts taken from the palate or any other area in the patient's mouth, of course, which is more tricky and perhaps demands more surgical techniques. So you simply use a grafting material and a membrane and sutures. So here's material that we have from Pergo. This is the graft collagen. It is a xenograft with a collagen carrier. We're going to use a small piece of membrane, and we're going to use these sutures as well. Now, if you look at the collagen carrier here, it comes in more or less of a block. What you simply do is that you add a piece of sterile saline solution, and you divide it into smaller pieces to adapt easier into the extraction socket. And if we go back to the case, we know here that we extracted a first premolar It is a two-rooted tooth with sectioned roots, and we fill gently the alveolus with the xenograft material. And we gently condense the material down into the socket. And when we've done this, we go to the membrane. So this is a resorbable collagen membrane. This is a small size membrane, and we just gently cut out the piece that we're trying to cover, and we suture up with a few sutures. Simple, straightforward technique, and this is more or less this is what you need to preserve the ridge. And if we go to the X-ray of this patient, what you see here is the outline of the previous alveolus. That again we have filled up with the grafting material, and what we know now with the sort of parameters that we have in research, we're going to keep the tissues in place. So we're going to reduce, of course, the effect of the resorption and remodeling of the ridge. So when we actually do perform the fixed partial denture, we're going to have a beautiful pontic site, and we know that we can keep this over time. So this is, of course, the key. We can also have a patient with an implant pontic space. And what does it mean, really? Well, an implant pontic space could be a patient like this patient. So here in the middle, we have a secondary molar that we know we're going to extract. So it's going to be a three-teeth edentulous space. So we're going to place two implants. And in the middle, we're going to have a pontic space. But of course, when we extract this tooth, we don't want to have a situation where we perform the final prosthetic reconstruction, and then over time, all of a sudden, we have resorption, remodeling of the ridge, and we have an unsatisfactory aesthetic and function over time. So when we place this implant in this patient's mouth, of course, then what we're aiming for? Well, we want to preserve this pontic site. And what you see here in this clinical picture is that this is exactly what we have done. I've simply used a xenograft with a collagen carrier, placed it into the socket at the time of extraction, covered with a small piece of resorbable membrane and a couple of sutures. Simple, again, straightforward technique to create this beautiful pontic site. And you can, of course, further sculpture the soft tissue with means of perhaps a temporary bridge, like we've done here. But again, what you're doing is that you're keeping tissues in place. This is, again, this is the key. And this is what we're all looking for. So here we see the final prosthetic reconstruction. So of course this is CAD/CAM made milled reconstruction, veneering with porcelain. And when we look at the clinical picture here, again you see this beautiful pontic site. It more or less looks like a tooth, and we know for sure that this is exactly the situation we're going to have over time. So this is very predictable. Again, it's a way of making sure that aesthetics and function are kept over time. And it doesn't matter if it's you as a general practitioner, whoever is placing the implants, but the person who extracts the tooth needs to take the decision at that time. What can I do to optimize the clinical situation for this patient? And that's the important thing. And this is what we're all talking about today, ridge preservation. And of course, we can do this with multiple tooth spaces as well. It doesn't have to be one single tooth. So this is the same sort of clinical decision tree. Again, the key rule here is to have an atraumatic extraction in all situations. Of course, as a prosthodont, I consider what prosthetic replacement am I looking for? What is the aim of the treatment of this patient? Well, is it a dental implant? I'm going to do immediate placement, again, early placement. Then, of course, we're not talking about ridge preservation per se. We may be placing the implants and doing simultaneous GBR. But as I mentioned before, most of the times when we look at implant cases in different markets, it's the late placement. Most clinicians, they wait 10 to 12 weeks for the healing process before they place the implant. If you are the referring doctor, you extract the teeth, then you refer away the patient to the surgeon. This is what's going to happen. And of course, what you want to do is that you want to optimize the surgical site for the person placing the implant. So the late placement, again, is a key indication for ridge preservation. And if you're aiming for a fixed bridge, again, you're looking at perhaps pontic sites. So what's the treatment for this patient? Well, this is a patient with periodontal disease. So this patient here is undergoing causal treatment performed by the dental hygienist for a number of months making sure that we have full cooperation of the patient before we move on with any type of prosthetic treatment. Obviously, this is very important key rules. What I know here is that we have tooth mobility on the neighboring teeth. So this is a period case. The patient is a male patient, 52 years of age. So the goal here for me as a prosthodontist is not perhaps implant treatment. It's more a fixed partial dentures premolar to premolar. So when I extract these teeth, again, the key decision here is how can I make sure that I keep as much soft and hard tissues as possible. How do I perform a Pontic site that looks beautiful over time? That's the key. So it's a clear indication again to choose the right technique and the right material. The previous cases I showed you with a single site, single edentulous space, we were looking at the collagen carrier with the xenograft. In these multiple extraction sites, you can actually choose another type of material. So here we're looking at a straight xenograft material, granulus. So this is not perhaps the collagen carrier, because we are preserving a larger site. There's more alveoluses than just a single site. So we're going to combine the grafting material, again, a resorbable collagen membrane, and a simple suture technique. So what we do, we take the grafting material, we add blood from the patient and a small amount of saline solution, and we mix it together. So we have something that is easy to adapt into the extraction sites. So what you see here in the clinical picture is that I've just added these grafting materials into the different extraction sites, gently condense them down into the tissues. Of course, make sure a thorough debridement, remove any type of granulation tissue, make sure that we have a clean site before we put this into it. So simple, straightforward techniques that you're all using on a daily basis. But the difference here is that you take in the decision to keep as much tissues as possible. So after adding the material, I adapt the collagen membrane, suture, and what you see here on the X-ray on the left-hand side is that I just filled up the extraction alveoluses. So it looks almost like a healed site straight after surgery. And what you see here also on the picture on the lower right-hand side, you see the temporary bridge that I performed in the patient. And what does it say here? Well, it says that I'm trying to shape the Pontic sites. So of course now when I let the temporary material go down slightly into the alveoluses, I make sure that I have a perfect situation after a number of weeks, and when I move on with the permanent reconstruction, I'm going to have perfect Pontic sites. And they're going to be perfect Pontic sites not only for the first few months, but for the rest of the patient's life. This is what we're aiming for. So again, a strategical decision taken at the time of extraction. So even if you are not the person who's going to perform the prosthetic reconstruction for the patient, when you extract the tooth, make the decision. Save as much tissue as possible. That's the goal. And obviously we have multiple indications for ridge preservation. We mentioned the late implant placement. Again, this is when you wait 10 to 12 weeks or longer before you place the actual implant. And it doesn't have to be you that perform the entire part of the treatment for the patient. It might be you who extract the tooth and then you refer away the patient to a specialist. But again, you made sure that the situation is more optimal when we actually place the implant. We showed you the single tooth space. So simple, straightforward again, a fixed partial denture. You do this every single day in your clinics. And again, you can have a better result in the end if you just try to preserve the ridge as much as possible. You have the implant Pontic space that I showed you, where you place implants and you have a Pontic site in between. Again, we're trying to preserve the space also there, not only surrounding the implants, but also the Pontic space. You extract multiple teeth, but still, we can of course add some material into these extraction sockets and again preserve as much tissues as possible. And not to forget and mention as well is the young patient. So younger patient with tooth trauma, severe tooth trauma. We know that these patients are not going to have dental implants because you have to wait a number of years before you actually place the implants. But what about saving the tissues that are there? Again, even if it's 5, 6, 7 years down the road you're going to place the implants, try to preserve as much tissues as possible. So again, at the time of extraction, you have to make the decision to do something to preserve the ridge. And we can look at many types of studies. This is another study by a group from 2019, where they're actually looking at classification of extraction sockets and a clinical decision tree for socket preservation. And I really like what they've written here in the conclusion, that based on current evidence, extraction socket preservation is suggested not only in clinical cases with dental implants being planned, but also to preserve alveolar bone for removable prosthetic fixation or to support soft tissue around fixed dental prosthesis. So that's like I've showed you in the cases. Again, ridge preservation is not something that is a pure indication for dental implant treatment. The indications are very wide. Most of your cases where you extract the tooth, you can take the decision to perform this simple procedure. What they're doing here with the decision tree is that they're mentioning different parameters for ridge preservation before implant treatment. So this is sort of a suggestion for a decision tree based on different factors. Aesthetic factors, functional factors, and risk factors. I'm not going to mention all of them, but what you see outlined here are different types of cases where you should consider as a clinician, if you face these clinical situations, it's a good idea to perform ridge preservation. So, like it says here, for example, in the functional area, if you cannot gain implant stability, or what we call primary stability, there's not enough bone beyond the apex of the extraction socket and the tooth, then it's not a good idea to place an implant. Then you're aiming to preserve bone and tissue before you do the implant treatment. And we can move on with different types of factors and situations, clinical situations, where you actually can perform ridge preservation. So I think that you're getting the message here. It's not only the implant patient, but it's any type of patient where you actually extract the tooth. That's the important message. Of course, it can be clinical situations where you avoid ridge preservation. So in cases where you have an acute infection, you have extensive swelling with pus, for example, large cystical lesions, it might be a possible oral-enteral communication, so what we call sinus communication. So if you extract, let's say, a molar in the maxilla, you divide the teeth and you have a communication. Of course, we need to cover this before. So in those situations, we're not aiming for ridge preservation. But these perhaps sometimes are quite few. So still, again, as I say, the indication for ridge preservation is extensive. So if we conclude what we have been discussing during these different types of cases, obviously, as I mentioned, there is extensive research published on ridge preservation as a treatment concept. We know for sure that ridge preservation is a very effective approach to reduce the dimensional changes of the alveolar ridge that takes place after tooth extraction. And of course, these studies are comparing, if you don't do anything, compared to actually performing ridge preservation. We know that bone substitutes together with the collagen membrane has shown clear effect on preserving alveolar ridge, width as well as height. And it's important to remember that it's not stated that it has to be one specific material. It's an osteoconductive material with a slow resorption rate and a collagen membrane. And I've mentioned a couple of examples of materials that I prefer to use as a clinician in my everyday practice. In clinical situations where you're trying to minimize the ridge reduction and the remodeling process, and that is a high priority, of course, preserving the ridge with an automatic tooth extraction should be considered. This is important. And of course, not all extraction sockets need to be preserved. But I think that it's very important for you as a clinician to remember, you should consider ridge preservation in every instance that you're removing a tooth in the patient's mouth. Because you never know what type of treatment you're going to do. You're going to do fixed partial denture, removal denture, implant treatment. But again, the goal here is to preserve as much tissue as possible. And as I mentioned, if you don't do this, you might actually cause secondary surgery to the patient, more money spent, more pain, higher morbidity in the cases, and this is everything that we're trying to avoid in our cases on an everyday clinical life. So I hope that you found this interesting and that you understand that ridge preservation is something that you can start doing immediately tomorrow. It's not difficult. It's just a strategical choice that you're making as a clinician to save as much tissues as possible.